Hello, I'm Dr. Antonio Colombo from Milan, Italy, and it's a real pleasure for me to lead these sessions about calcified and complex lesions. There will be 3 presentations. The first one will be performed by Dr. Shigeru Nakamura about rotablation, when and how. Then Thierry Lefevre will discuss various debulking devices other than rotablation, when and how to perform. And finally, Dr. Jung-Min Ahn will discuss how to obtain maximal support to severe calcified lesions. So let's start with Dr. Shigeru Nakamura.
Okay, thank you very much, Dr. Colombo, and then all participants. So nothing to discuss about this presentation. So the rotablation was invented by Dr. David Out, remove non-elastic tissue from coronary artery region. So this is the device console and the advancer, and this is the tip of the device, which has the diamond coated. The wire is 0.009 inch, so the diameter of the device is like 1.25 to 2. This is a semi-French guiding compatible. Maximum size 2.25 now. So mechanism of action, an abrade hard plug into microparticle. So this rugby ball head has 5 micrometer exposed diamonds. The microparticle pass through the coronary circulation, then removed by the reticular endothelial system. So this is the particle of the abraded things, and red blood cell is usually 8 micron. So these stuff goes through the microcirculation. So ratio of rotablation used for our hospital, so like 2002 and 2003, which was 16%, because at that moment, bigger is better. So, but after the 2004, we are reducing the rotablation use because the cipher was coming, which was too good. So just stented. So what are the hurdles to use rotablation? It is difficult to predict complications such as slow flow and perforation. Many lesions can be treated with high pressure drug-eluting stent implantation. We have changed. We started to use OCT actively at 2013 because we were preparing bioresorbable vascular scaffolding. However, it was not approved in Japan, so the IVAS is sufficient for standard treatment. But this is a memorable case, 2015 December. The case was introduced to our hospital from other hospital to do the rotablation for LED lesions. So this is the second session to the circumflex osteo lesion. So this is the OCT before intervention. So this is the OCT image. So what I understand is we cannot see whole vessel, but we can see the wire and narrow lumen, and wire is biased to the plaque side. So when you see by fluoro, wire is attached to the plaque side. So I used the 1.25 bar 150,000 floppy wire 4 times. This is a post rotablation. So it looks the dissection, but when you check the OCT, we can see the clearly calcification is cutted here, and wire is biased to the 6 o'clock, and this is a good wire bias. So I size up to the 1.75. So this is 1.75 bar. This is a post 1.75 abrasion. The CX ostium looks the delta area, so looks at the large dissection. But when we check by IVAS, this is some kind of reverberation here, but what we know is this is difficult to judge. things. So when we use OCT, we can see the clearly cut off the mark of the calcium surface. So this area is not dissection, it's enlarged lumen. So when we compare the three pictures here, sometimes the soft tissues on the calcium. So from the beginning, now we can see the calcium here. But after several cuts, we can see the clear cut of the calcium, and then we can do more ablation here. So this is a pre and the post 2Y stent, and this is a 15 months follow-up. So some kind of proliferation, but no restenosis. So we have learned how the rotablation works. So ablation effect is seen at wire bias site. The treatment becomes interesting when feedback is obtained. The frequent use of rotablation has increased. So recently, as increasing complexity and calcification in PCI patients, the beginning of PCI era, the type C lesion was less than 20%, but recently we are expanding the indication, so increased type C lesion. When we check by calcification, beginning PCI era 24%, just before the cipher 25%, but now 32% region has calcium. So debulking device use for hospital is increasing. I think average use of rotablation in Japan is 6 to 8%. But after introduction of OCT, increasing the rotablation case, and 2017, we use a 25% of patient we use the rotablation. And then 2018, Diamondback comes, and then if we get together, a total 31% used debulking. So what kind of lesions should be considered for rotablation? So this is a calcification clearly seen by fluoroscopy. So this is a silhouette of left coronary artery calcium by filming. So this is Leo. So this kind of vessel is less elastic, so we prepare for the rotablation. So OCT did not cross at the beginning. I used a 1.25 millimeter rotablation, 160,000 with extra support wire, and 4 times 4 pass. Still thick calcium there. So after the procedure, we checked the OCT again. So this is the diagonal here. This is septal. So epicardial site is this one. So the main target lesion here, the wire is biased to the 10 o'clock and no calcium at this area. And then just with distal here, some injury or some cut here. And when you check by iliocranial, so type this B lesion, wire is biased to the diagonal side, and also this part here. And interesting thing is this part is very hard calcium there. So the wire is biased to on the calcium side, and you can see the cutting marks on this 5 o'clock. So if we size up this case, we have a risk of the perforation of this area, so we cannot size up this case. So we did a squatting balloon and stent, and then final NSC balloon. So we made a crack using the NSC, but even made a crack on the calcified plaque, lumen gain is limited after stenting with high pressure inflation. This is 3.7 to 5. Angiographically looks fine, but the lumen was only 5. So this is the other case of the calcified nodule case here. And this is the calcified nodule. The wire is attached to the calcified nodule. And then I started to use down the back, and it's ablating this 3 o'clock side and good wire bias. But still rotable calcium remained, and I changed to the rotablation 2.0, and the cutting balloon, and finally I use a DCB because we could enough remove the calcium. And this is 8 months follow-up. There's no restenosis. And when we check by the fluoroscopy, you can see the calcified nodule here. And this is after OAS. You can see still thick calcium there, and we size up to 2 rotabrator, and this is follow-up. So the comparison of drug-eluting stent versus drug-coating balloon after rotation atherectomy for severely calcified lesion of non-small vessel. So this is rotabrator DS, this rotabrator DCB, and reference diameter 3.03 and 2.97. So post-percent stenosis 1%. Rota plus DS very good. Rota plus DCB is 22%. And 8 months follow-up, percent diameter stenosis by DS 18%. Rota plus DCB is 32%. And late lumen loss, Rota plus DS 0.29, Rota plus DCB 0.31. And the restenosis rate of this 6%, 9%. So TLR is 5%, 80%. And this is not so bad if we try to do the aggressive rotablation. So the summary, so moderate to severe calcification, think about rotablator. So use intravascular imaging, you can maximize calcified plaque reduction with rotablator when good wire bias exists. It is necessary to gain a certain number of case experiences. Thank you for your attention.
Thank you very much, Shigeru. This was a very interesting presentation discussing very deeply imaging as well. Now we go to Thierry Lefevre, who is going to discuss other debulking device besides Rota. When and how to. Thierry?
Thank you very much, Antonio. So I will try, after this excellent lecture of Dr. Nakamura, to explain how to use other devices than rotablator. This is my disclosure. I think it's very important to have in mind that we are treating all patients who are getting older every year. And this is the rate of calcified lesion in this registry, US registry. You can see that this rate is increasing. So if you continue like that, we'll be close to 25% or more of patients who had significant calcified lesions. Of course, identification of calcified lesion is not so easy, and by angio, we are underestimating calcification. So that's why Dr. Nakamura insists on intracorneal imaging. I think it's very important, especially when you use rotablator. Stent boost is, in my opinion, too much underused, and it's a very good tool to identify calcification when you can put a balloon at the lesion of the lesion. So of course, when you have calcification, you have more risk of the procedure because crossing the lesion is not always easy. Opening the lesion with a balloon is not easy. Stenting the lesion because in terms of deliverability, risk of stent disinsertion, risk of mal-expansion, risk of damaging of the polymer, so which create restenosis at follow-up, and of course, risk of perforation, thrombosis, vessel rupture. This is the only study that will show, which come from Philippe Généreux, and you can see that when you have moderate to severe calcification, you increase the risk of death, cardiac death, target lesion revascularization, and even stent thrombosis. So it's very important to have that in mind. So now we have learned that the problem is related to many parameters, and the more important is the length of the calcification, the thickness of calcification, and the arc of calcium that you have by intracoronary imaging. So which device we are available? Of course, these are not really debulking device, but it helps to expand the lesion, like the cutting balloon, scoring balloon, a special balloon with a wire, but also there is a non-compliant balloon and special OPN non-compliant balloon, which can go up to 50 atmosphere, which are very useful to treat this kind of lesion, even sometimes after rotablation. Of course, there is true debulking device like the Rota, laser, diamond back, and of course, these are very useful too. And now we have also the Shockwave technology, which I think is very useful, and I will talk a little bit about that. So when on how to use debulking devices other than Rota, I think it's very important to understand that the first step is to assess the vessel, the diameter, the risk of tortuosity, the support that you may have to reach the lesion, and of course, the length, thickness, and arc of calcium. It's also very important to have an optimal lesion preparation, and I see too many cases where the stent was deployed and then the operator realized that the stent is not open. So vessel preparation is crucial, and all these devices are very useful, including Shockwave technology when you can reach the lesion. So check for optimal stent apposition and expansion, and of course, stent boost or stent vis can be useful. Of course, intraocular imaging is also very important. And it's very important at the end, if the stent is not fully open, to use a balloon, a very high pressure balloon that may optimize. And sometimes Shockwave can be also useful after incomplete stent deployment. So I will show you some examples. This is a non-crossable lesion, which looks not highly calcified. It's a quite a CTO lesion with probably recanalization. And you see that we have a good support with an emplats. We are not able to cross, so we use extension catheter, and Dr. Hahn will talk about that after me. This is, and you can see that we are not able to cross with a balloon or with a microcatheter. So we use laser, and you will see that with this support and the laser, we'll be able to cross without any difficulty this kind of lesion. So laser for uncrossable lesion is really the best tool that that we have. This is the final result. Now there is cases who looks not highly calcified, like this case. So you have a relatively short lesion, not very calcified. I think if we use intracorneal imaging, we understand the problem. You can see also that there is calcification of the mitral annulus and aortic stenosis also. So maybe you should have anticipated that this case maybe will be difficult. So the operator starts with a non-compliant balloon, which was not able to the lesion. Then a cutting balloon, which was not able to open the lesion. Then rotablator, 1.25, which was able to cross. And after that, the operator used a non-compliant balloon, 2.5, and you can see that there is still some residual lesion. So the lesion was not fully open at 22 atmosphere. But they decide to use a stent, thinking that they will be open to able to open the lesion. And you can see that again, the stent is fully open at this level, but not fully open proximally, despite high pressure. So in this case, what is the solution? You can use, of course, cutting balloon after stent implantation, but it's not easy. So we use a OPN balloon, non-compliant, and you can see this is at 40 atmosphere. So we have still a waste on the balloon at 40 atmosphere for 45 seconds. Then we increase 1 by 1 atmosphere, and you can see at 42, the lesion was open. So this is very useful because you may have a lot of cases like that if you have not an optimal preparation of the lesion before. So this is the final result after using the OPN balloon. Now there is this case, I think it can be a very interesting case. So it's an old woman, 88 years old, who was admitted in hospital for aortic stenosis. So we were doing a TAVI screening, And you can see that on the left system, there was calcification, but not significant disease. But on the right, you have this highly calcified lesion, nearly subocclusive. And in my opinion, there is some risk of using rotablation in this case, because if you have soft flow or no reflow with a severe aortic stenosis, you have a big risk during the procedure. So we decided to use the Shockwave technology in this case, and it's just to show you what happened when you activated the Shockwave. You break the calcium, this, of course, with this technology, you give a series of 8 activation every 1 second, and then you can redo it for 10 cases. There is a lot of studies, District CAD1, which was a single arm study, then CAD2, and the CAD3 was presented at the last TCT. So I will just show you what happened when you activate the Shockwave technology. You really break the calcium, and then you are able to open the lesion easily. Of course, the balloon is like a non-compliant balloon, so it's not a perfect balloon to cross the lesion. And during the last TCT meeting, Dr. Kyriakis presented the result of the study, showing that compared to orbital atherectomy, you have really a better result in terms of safety and effectiveness. So let's back to the case. You can see that we are poor support with the GR because the lesion starts at the ostium. We have crossed the lesion, and then we have predilate with a 1.5 balloon, just to have some space to be able to put the balloon in place, the Shockwave balloon. So this is a fluoroscopy showing that we're able to advance through the lesion with a 3012 Shockwave balloon. And then we have activated 8 series of 10 pulses at 4 atmosphere. You can see there is still a waste after this. Then we move to a 3.75 balloon, Shockwave balloon. And this is the result after 5 series of 10 pulses at 4 atmosphere. So you can see that now the waste has completely disappeared. This is the result with the balloon. And you can see now that it's a very big dominant right coronary artery. And this is after stenting, which I think looks very promising. So I will try to summarize that in this last slide. So when you have calcification, start with optimal guide support. When you have mild to moderate calcification, if you have easy access to the lesion, you can just use non-compliant balloon or Shockwave technology. And if you are not able to open the lesion, the rotablator can be very useful. But and then after you can use again non-compliant balloon and stent. If you have complex access, it's a little bit different. And clearly, a rotablator can be a very good option. And then you can use Shockwave or OPN balloon and stent. Now, if you have a severe calcification or nodule, it's a little bit different because the majority of cases, it's a complex lesion. So you can start with rotablation. Or if you have easy access, then you can use the Shockwave technology, and especially in case of nodules, it's very useful. Now for uncrossable lesion, that like I said before, I think laser technology is really the best that you can do for this kind of lesion. Thank you very much for your attention.
Thank you very much, Thierry. Very comprehensive review. I believe between Shigeru and your lecture, we have a good assessment of calcified lesions. Now we conclude this series, and then we will have questions. Dr. Jung-Min Ahn will discuss how to obtain maximal support for severe calcified lesions. Dr. Hahn?
Yes, thank you, Antonio. So my topic is the obtaining the maximal support for severe calcified lesion. So how to get a maximal support for complex PCI? I think a coaxial guiding catheter is very important. And strong guiding catheters, M+ EBU, the XB rather than jockeying is a good way to get strong support. In addition, the aggressive lesion modification is very important for get a strong support for particularly calcified lesion, high pressure balloon, or rotabulators. In addition, compared with the smaller lumen guiding catheter, larger size guiding catheter may have the stronger support for the complex lesion. In addition, anchoring technique, side or distal anchoring would be a good option for get a strong backup, and deep intubation of a guiding catheter would be one option. So this is a the intubation of a guiding catheter. So when you insert the jockeying guiding catheter into the deep and LAD guiding catheter into the deep LAD can make a very strong backup support, even in the very calcified coronary artery disease. However, the guiding catheter may damage to the coronary artery system. So the total catheter was developed. We have a second generation mother and child catheter systems, guide liner and guide Giller. There's no big difference between the two, the total catheter system, but the guide liner is more flexible, guide Giller is more pushable. The clinical indication is has a very long list, but whenever you need, you can use it. So even in the weak guiding catheter support, when you use, if you use the total catheter system, guide Giller, guide liner, you can get the very strong backup for the treatment of a severely calcified lesion. So how to insert the guide extension catheter? This is a case of the insertion of guiding catheter, guide extension catheters. So introduce the balloon first, and then using the balloon as a guiding, then you can insert the guiding guide Giller into the deep portion. In the very tortuous and calcified lesion, we want to treat the OM branch, but the very calcified, very tortuous lesion, so we need a more strong guiding catheter, more strong the catheter backups. So insert the balloon, and using the balloon as a guiding, and you can insert the total catheters guide Giller. So ballooning, and you can insert the guide Giller and deflation balloon and advance the balloon further, and you can go to the deep and deep and deep. You can come to the final lesion, and you can easily deliver the long stent like this, and and then you can treat it successfully very calcified, very long calcified lesion tortuous with the tortuosity. So we use very frequently guided extension catheter, guide Giller, guide liner. So I like to share our cases. Very calcified lesion, tortuous calcified lesion. When you insert guide Giller, guide liner into the middle portion, this provided a very strong backup for the delivery of balloon or stent. You can treat it. Even in a very weak guiding catheter backup, for example, because of very weak guiding catheter backup, we cannot deliver any device to the lesion. But when you insert guide Giller into just before the lesion, you can deliver the device, and then you can treat the lesion successfully. Even in the very tortuous artery, so even though you use the very strong guiding catheters, the device cannot deliver frequently delivered to the distally But when you insert, if you insert catheter, then you can deliver the balloon to the stent to the lesion. Ostial lesion, yes. Ostial lesion, using the guiding catheters, you can engage the lesion, and then you can deliver the device. And sometimes lesion is very distal, like this. You cannot deliver the balloon or stent. Then you can deep engage the catheter to the distal, and then you can deliver the stent and balloon. But it tortures on normal coronary ostium, so we cannot make the strong guiding catheter backup because of abnormal coronary ostium. So after we insert wire, and if we use the catheter, and you can successfully treat the lesion even in case of abnormal coronary ostium. So abnormal LAD from the RCA, we want to treat the mid LAD here, but the long way. So very long tortuous lesion. So when you insert the catheter, you can treat the lesion like this. So the stent delivery through the stent is very hard, very difficult. So in this case, you can insert the catheter like this, and then you can deliver the stent through the stent like this. So in case of very distal lesion, distal calcified lesion, so rotablation, you can deliver the rotabulators using the catheter. Insert the catheter to the distal RCA, you can deliver the rotabulator, and you can treat the rotabulation even in the far distal RCA lesion. But in addition, selective angiogram can be done by the catheter. And bifurcation side branch device delivery, the insert catheter to the just opening of the side branch, then you can push the balloon to the side branch. You can successfully deliver the balloon to the side branch like this. So this is very convenient, very useful for the treatment of calcified lesion, tortuous calcified lesion, when you needed some strong backup, further backup. But we have to know the complication. The first, the inside of catheter, the stent can be deformed. So when you feel the resistance, please don't push a lot, because inside of particularly connector area, make some damage to the stent. So to be careful. In addition, the first spray injection can make some damage to the coronary system, particularly in deep engaged case. If you do the first spray injection, can make some dissection. So in addition, deep engagement, you have to closely monitor the pressure, so avoid the pressure damping and ischemia during the procedure. So this is complications. So we have to know what is the complication of deep engagement of catheter and catheter liner. This is my final summary. For device delivers, vessel lesion resistance should be overcome, particularly in the severely calcified lesion. Strong support guides and deep intubation are often useful. Guide extension catheter is very useful and can overcome limitation of poor guiding support and enable procedures otherwise not possible. For the complex PCI, guide extension catheters is a game changer. Interventional cardiologists should be familiar with these vital tools. Thank you for your attention.
Thank you very much, Dr. Hahn, and thank you for this very nice review regarding using mother and child new generation catheters. We have time for discussion. Please go ahead. Any questions? Maybe we can start with the first presentation to Dr. Nakamura.
To Dr. Nakamura.
Yes.
Could you sort of describe what your approach is to improve wire bias when you see unfavorable bias? Do you change the wire to extra support, or do you have any other tips and tricks you'd like to share with us?
Yeah, thank you for your question. So I think it's almost difficult to control the wire bias position. So if the wire did not touch the surface of calcium, we can do more. So this is a limit. Maybe the shockwave can solve this kind of wire bias problem.
Shigeru, when we don't have orbital atherectomy in Europe for coronary yet, and I hope we will have, do you believe that when you have unfavorable wire biased with orbital atherectomy, you should activate the burr on the way back instead on the way in?
Yeah, so the basically the diamond back is better to use a pulling back system. So if you push the bar is going outside, so sometimes they get the perforation, but mainly running on the wire. So especially in the bend lesion, you start with the pull back, and then bring the wire bias much more inside. And then if the wire is come to inside, you can go back and forth.
So it's an advantage that you can ablate also on the way back,
Yes.
not only on the way in. We always told Boston Scientific to make the burr coated all the way.
Yeah.
So you can you avoid the trapping, you avoid everything. I don't understand why they never did it. We even filed the patent, but nothing happened. Okay.
So,
I have one
Dr.
question to
Nakamura,
Yes.
Dr. Nakamura, I have
Please.
one question. I'm Joo-Yong Han from Samsung Medical Center, Seoul, Korea. Do you have any specific criteria for upsizing of a rotablated hole based on the OCT or iris?
Yeah, so I think if you can see the calcium thickness, and then if I use a 2.0 feel good. So usually we use a 7 French guiding, so the maximum aberration is available only 2. So depend on the good wire bias and residual calcium thickness. So we have to keep the safety margin.
Do you have any criteria for the thickness of residual calcium for upsizing, or just your feeling?
No, most of the time we can check the visual estimation just from the picture.
Mm-hmm. Yeah.
So
I have
do you have a
to
ratio? Excuse me. Do you have a specific ratio between the vessel size and the burr size? Is it 0.6, 0.7? What is your general rule?
So so because the problem is the rotablators, we cannot estimate something happen. So if the long diffuse disease, we start with a smaller bar size to check the reaction of the artery. So, and maybe we need, in Japan, we can cover by 2 bars, whereby insurance system, we can start with the model size. And if there's nothing happen, we can jump up to the 0.5 millimeter more. But this is difficult, depend on the case.
So I have a question both to Dr. Nakamura and Fube. Do you have any tips to treat the calcified nodule? The ring sometimes the calcified nodule is more difficult to treat than the ring calcification. So how to treat I'd like to ask your tip and tricks.
So I think these are also that depend on the wire bias. if the wire bias is good, you can maximize the largest bar. And if you can make another route, you can make a two-route abrasion when the nodule is very large. But these are also, they depend on the case. So I think the repeat intervention. So we want to do the abrasion and scoring balloon and DCB. If the patient come back, we can do second chance.
Well, I have one question, but the question is both for Dr. Nakamura and Thierry. You both mentioned that IVL can be used in certain situations with heavy calcification. But my understanding is that you need to have a large arc of calcium, otherwise the IVL won't work. So let's say if you have a nodule, but the rest of the vessel wall is not so calcified, do you think IVL is good in that situation?
I'm not sure that we have only the clinical trial experience. So maybe surrounded calcium is good, but partial calcium, I think energy is losing some parts. So it's difficult still.
I think that nodules are relatively a good, IVL is a good strategy for nodules, even if it's completely eccentric. And now we have that, at the beginning they said, okay, it should be concentric and the result is better. But now we have data showing that even when you have eccentric lesions, we can break the calcium where it is.
Is there any rule or minimum arc for the IVL to work? Let's say if the calcified arc is less than 90 degrees, what do you think still?
I think when you have calcification, you will break it. So I think there is no, we have not full information about that, but I think our experience is that it always works. When we think that we should use a device because there is calcification, significant calcification, it works.
Okay. So in your experience, when you treat a nodule with IVL, do you have to give a lot of the pulses in that one spot? Because I agree, I mean, our experience with the nodular calcium is that, limited experience, but the IVL doesn't seem to work so well with it. So I'm wondering, do you have a different approach if you see nodular calcium and IVL?
Yeah, we move a little bit around the nodule in order to give many pulses at the level of the lesion, but we move just a little bit. Depends on the length of the nodule, of course, but and what is also very important is you have to correct size of the balloon. So if the vessel is 3.5, usually we use a 4.0 balloon at a very low pressure, 3 atmosphere. But maybe Antonio has also a lot of experience with lithotripsy, so maybe you have different opinion.
I share some uncertainties about the nodules. We had last week I had a good result of a stent underexpanded with a nodule, and the week before a baseline nodule, no improvement. I finally got a good result with cutting balloon. I don't understand why. I think we need some more data. Maybe the orientation of the piezoelectric has to be in the same axis of the nodule. So maybe just a matter of luck. If we are in the same axis, the nodule is broken. If we are on a different axis, the nodule is not hit. It's like firing with a gun. If you don't hit the target, if you have calcium at 360, no matter where you fire, you hit something. But this is my theory. I don't know if it's true.
But you have seen, Antonio, that when we activate the lithotripsy, you see a wave which is really around, so 360 degree, and the wave is very powerful. So yeah, I don't know.
But I heard this comment about no good result with nodule by someone else. And some people say good result. So I think it depends on the, I don't know. I think the nodule is something to be investigated.
I agree.
Well, I have one question for Dr. Ahn. In your nice presentation, you tell us the guide extension is a really good tool for us for a very tortuous, especially calcified vessel. But you also mentioned that it helps the delivery of a burr. In my practice, if I want to use a guide extension with a rotablation, I will always preload the burr inside the guidezilla before I deliver into the guiding catheter. Is that your practice, or you advocate that you can use the guide extension and then deliver the burr just like any other guiding?
So the big burr cannot deliver through the guide extension catheters. Only 1 to 5 and up to 1.5 we can deliver through the guide extension catheters. So the my case I showed you before is the 7 French guiding extension catheters. Through it we can deliver the 1 to 5 and 1.5 burr. So
Well,
we didn't preload.
My question is not about the profile or inner diameter of that guide extension. It's about the delivery of the burr over that connection portion inside the guiding, because it's possible that during the delivery of the burr, even at the dynaglide, you can damage that connection point.
Yes, the previously I thought we couldn't deliver the burr through the connection point, but nowadays last week we found out that we could deliver it through the over the connection area, so we can deliver it.
But you know, if you are afraid of damaging the connection point, you can deliver the rota burr in the old-fashioned, just like advancing, like if you're advancing an over-the-wire balloon. So without dynaglide, then it's a little bit more time-consuming. But I wanted to comment about the presentation of Dr. Hahn. I really like your presentation because I am an old-fashioned interventionist, and every time I see someone using a guide extension, I say that he does not know how to use guiding catheters, because we worked for 25 years only with guiding catheters. But I believe we have to be more updated. And the guide extension is safe, makes you save time, contrast, and should be used more. It's not an excuse not to learn to use guiding catheter, but the threshold should be lower, not wait longer, because the cost of the extension is paid back by the procedural time, etc.
I think, Antonio, this is a very important point. We learned in my center to use it 15 years ago, and for me, it was really a revolution. So using extension catheter, as you said, save time, save complication, increase the rate of success, increase the rate of the stent delivery. So it's really a tool which should be used in all cath labs.
Yes.
And Dr. Ahn showed very nicely how to use it, how to deliver, in which case it's very useful. You start with a poor support, you improve your support. You have difficult access because of anomalous coronary arteries, you can solve this issue. So it's really, for me, it's really one of the revolutions that we have since the last 15 years.
Very important.
And also, may I add, Dr. Ahn mentioned that one of the pitfalls for guide extension is damping, pressure damping, and also ischemia. But I understand that in China, they have made some guide extension with side holes proximal to the end. So with that kind of device, maybe you can advance your platform very deep down without losing the pressure feeling from the upper stream.
Yeah, I hope I use it in the near future in Korea.
Okay. Any other, if there's no other questions, I believe we can finish this session on time, maybe some minutes ahead. I believe to summarize, we discussed with Shigeru the update and the more modern use of rotational atherectomy. Thierry discussed other device, including laser in some situation, maybe a good adjunctive tool, OPN balloon, and Dr. Hahn, the guide extension, which is not so new, but is something that we have to be more liberal to use to make procedures safer and quicker. So if there are no other comments or questions, I would like to thank all the presenters. Thanks the organizer for setting up this interesting session, and wish everybody a good day or a good evening, whenever place you are. Bye-bye. Ciao.
Bye.
Thank you,
Bye-bye.
Antonio.
Bye-bye.
Thank you.
Bye.
Thank you.